Hello, good evening, sir. Thank you very much for joining in this webinar for today's. So I would like to introduce our moderator for this program today, Dr. Professor Subro Banerjee. He is a senior consultant interventional cardiologist of Apollo Multispecialty Hospitals, Kolkata. And now I will hand over the session to Dr. Subro Banerjee. The first case will be presented by Dr. Raja Nag. He is already ready, sir. Sir, you can just start, sir.
So good evening and welcome, colleagues, to the first chapter of the Eastern Cardiology Conclave. We have 4 luminaries with us today, who would be panelists as well as speakers too. Now, there is a little change in the order, and the first presenter today is Dr. Raja Nag, and he's a senior consultant interventional cardiologist and a colleague of mine at Apollo Multispecialty Hospital, Kolkata. So could I invite Dr. Nag to share your screen? And also could we, I don't see any other panelists now at present, so I think we'll discuss this case till the other panelists join. Okay, well over to you, Dr. Raja Nag.
Thank you, sir. Good evening, sir. So I'll share my screen. So, is my screen visible?
Your screen is visible, but not the slides.
Yes, sir. Give me a second.
Okay, sure.
So my topic today is OCT guided PCI of instant restenosis in a patient. So let me start the slideshow. Yes. Good evening, everyone. So let us go into the case directly. So my patient was a 70-year-old man, hypertensive, non-diabetic with angina since last 3 months, significant angina and jaw pain, and he was on maximal medical management. So he has a long history with the cardiology department. In 1999, he first underwent bypass surgery with 3 grafts with Lima to LAD and venous graft to OM and diagonal. Then in 2011, he underwent his venous graft stenting to the diagonal. 2015 again, he underwent stenting of his native RCA this time. And 2018, he underwent his stenting of the venous graft to the OM. And 2019, in the first pandemic, he presented with acute LVF hospitalization with ejection fraction of 30% and atrial fibrillation. So he was managed medically in 2019 and then discharged, and angio was not done at that point of time because his creatinine has shot up. Then again in 2021, he presented with severe teeth and jaw pain on mild exertion. ECG this time was showing atrial fibrillation with controlled ventricular rate, with ejection fraction of 45% this time, with maximum medical management with the current drugs like Vimada and Pagliflozin. He also had a creatinine of 1.4 this time. These were his medications, and we took him to the cath lab. And by the way, his troponin was elevated. So we decided to do the angiogram this time. These are his native vessels. So this was his native RCA, which showed a significant instant restenosis in the mid portion of the stent. So these are shown in the different views. Like you can see, it's a tight stenosis. These were his venous grafts. It was not flow limiting. So we decided to not to intervene in the venous grafts. His Lima was also flowing. So the plan was to do a OCT guided PCI of the instant restenosis of the RCA to understand the pathology of the instant restenosis mechanism. This time we counseled the patients and decided to go the femoral route with a 6-French JR and 2 wires of Sion blue and BMW wires. Wiring was not difficult. So we took P dilated with a NC balloon of 2.512. But as you can see, the balloon inflates, it shows a significant waste in the superior margin. So after that, because before that we would not have been able to take our OCT catheter across the lesion. So this was the first OCT run. You can see the proximal part of the stent, which was quite well opposed and expanded. So as we come to the mid portion of the stent, there is significant new intimal hyperplasia along with significant lipidic pool with some amount of calcium. So according to the MLD max, we took the reference diameters and the length to be intervened. So these are some pathological slides, which we all know shows like intimal hyperplasia. So these are the different types of instant restenosis patterns. So these are important to understand that what kind of intervention would be beneficial most for the patient, whether to do a stenting or a drug-eluting balloon. So these are the different reference diameters we have taken. Now after that, we took an angiosculpt of 310 and pre-dilated in the most critical part and went up to 18 atmospheres. But still then there was some amount of waste. So now I took a OPN of 3 to 10 millimeter and went up to 40 atmospheres. And this time it looks it has given. So we took another OCT run this time. But OCT run still showed there was some amount of new intimal plaque still remaining. So these are the two, these are the 3D rendering of the OCT run. As you can see, we are proceeding from proximal to distal this time. On the upper left corner, you can see both the wires. So now we are approaching the most critical part. Like you can see, it is well dilated and there is good luminal gain. And the best part is inside the stented part, the stent was well opposed and there is no significant intimal hyperplasia inside the stent and distal to it. So the plan was to do focal stenting from the restenotic part up to the proximal edge where we could find a normal lumen, and decided to do a 3.5 and 28 millimeter drug-eluting stent. So this was a stent which was deployed up to 12 atmospheres, post-dilated. So this was the final result. And this was the final run, which showed a well-expanded area in the overlapping part of the stent. Like you can see from the bottom longitudinal figure. And also the stent was well expanded. So this is the most critical part in which the stent is overlapped. So we are happy with that and left him alone and discharged him after 2 days. So the mechanisms of drug-eluting restenosis we all know are biological, mechanical, and technical factors. And the treatment of ISR all depends on the pathogenesis or the pathology of the instant restenosis. And in this era of drug-eluting balloon or drug-coated balloon showing good results, if we can show by image or have seen that there is underexpanded stent and not significant new intimal hyperplasia, we can get away with doing a drug-coated balloon and not put in a stent, which may lead to further TLR in future, because we all know that repeat PCI in a stented segment with another stent leads to significant amount of MACE, and the TLR rates are as high as up to 80%. So to conclude, the management of patients admitted with ISR and stent thrombosis is challenging. Interventional treatment has already failed because of restenosis. There is often underlying causes that led to this event. The event rate following repeat PCI, as I've said, is very high. OCT imaging or IVAS should be routinely used in these patients to understand the causes of ISR and guide the treatment and evaluate procedural results. Thank you, sir.
Thank you, Dr. Nag. I think it was a very good presentation, and I think I would have done exactly similar way what you have done. A few things for discussion. Firstly, This patient, there was significant intimal hyperplasia, but was the stent expanded? I couldn't actually read out the stent area or the, which you showed in the OCT.
In the first stent, which was deployed in 2019.
Huh?
Yeah, yes, sir. From the OCT images, we could see the stent was well expanded, but there was significant new intimal hyperplasia.
Okay, so the cause was new intimal hyperplasia. There wasn't any additional under expansion of the stent. Okay, so
we did not overlap the entire stent.
Oh, the hyperplasia did not overlap the intestine. Is that what you said? Yeah. Okay. Yeah. And rightly, you have used a cutting balloon there as well, because that was quite diffuse. And the another thing is like the creatine was 1.4. Were you a little concerned about that using creatine?
Yes, sir. I was concerned about that, but yeah, I understand why you're asking. Why did I go ahead with the OCT? Sir, in instant restenosis, the best resolution images are obtained only by OCT and not by IVAS. So to understand the pathology or to understand the immediate layering of the stent, so OCT is the best modality and not IVAS. So even though his creatine was 1.4, after the first angiogram, I waited for 48 hours and then took him up after 48 hours with adequate hydration. And post stenting also, I did a RP2 or a creatine in run, and it showed around 1.6. And I was happy it did not shoot up too much, and he's on follow-up and he's doing well.
Yeah, I mean, IVAS is certainly OCT is superior to IVAS in ISR, but if the had the creatine beta a bit higher, you might have changed the decision and gone for a IVAS.
But then we have options of doing with a dextran, but the images are not as good as.
Yeah, but I think hydration actually serves its purpose most of the time. Yes. And why did you use the OPN balloon? Did the non-compliant balloon actually? Did you try a non-compliant balloon first and it didn't work and you went to
with a non-compliant balloon, sir? After that, I used the angiosculpt, and then with a suboptimal result, I thought that OPN would be a good choice. And I know OPN usually we do for post dilation, but in this case, I thought this will help me because in the stented segment there was significant amount of calcium, and we needed to achieve a good result because unless we achieve a good bed post stent, he will have a high TLR because there is already a metal inside his right coronary.
And what were your thoughts like about choosing another DES rather than going for a drug-eluting balloon? I know you have actually showed a slide, but this is just for discussion. When would you have used, I'll put it this way, when would you have used a drug-eluting balloon instead of a DES?
Right. So this is a very important question. And like now, if we see that the stent was under-expanded and there is no significant new intimal hyperplasia or there is no calcium and the stent was just under-expanded and it is early stent restenosis, then we should do a drug-coated balloon, and the results are fantastic with the present paclitaxel drug-eluting balloons. And it has also been shown that patients who have instant restenosis, who have focal instant restenosis, when the edges are clear, the proximal or the distal edges do not have any significant restenosis, then we can get away with a focal drug-coated balloon, and the results are very good. Agreed to that. But in my case, there was significant new intimal hyperplasia along with calcifications.
Yeah, absolutely. And also there were disease in the proximal part as well, isn't it, at the edge?
Yeah, proximal, there was a significant lesion. And that is where the role of OCT was very important in this patient. If I had seen that there was only an under-expanded stent, I would have gone ahead and done a cutting balloon and then expanded it with a NC balloon and then do a drug-coated balloon, and the results would have been as good as with stenting.
Yeah, great.
Yeah,
well,
better without.
Yeah, I think Dr. Shatpathy is there. Dr. Shatpathy, would you like to comment on that, or Dr. Kaur? Did you actually see the case, or did you miss it?
I'm sorry, sir. I think I missed it.
All right. This was a case of as an ISR in a RCA where OCT was done, and it actually showed that there was significant restenosis, mainly because of intimal hyperplasia. The stent was well expanded. So another DES was put in after dilating with, after using a angiosculpt and dilating with an NC balloon and also a OPM balloon. And then it was done well. So yeah, so that was the case. I think we have to, so let's move on then. We can, or maybe Dr. Kaur, would you like to give your opinion, like when would you have used a DES in such a case in an ISR, or where would you use a drug-eluting balloon in a case of ISR? It's just a general question. I know you haven't seen the case, yeah.
I know. So the general tendency is that if we can reduce metal load in an artery, we'd always try to do that. So I think ISR presents us with a very unique opportunity to do that. So provided we have controlled dissections after the angiosculpt, and the fact that we have good achieved good lumen size, yes, a drug-eluting balloon is always a very good option, provided we have good imaging. So unless not you size your vessel well, a drug-eluting balloon it's generally not effective. So because it has to oppose the walls and has to deliver the drug adequately. So yes, definitely it is a good proposition depending on what kind of ISR and whether there's peri-stent involvement. So let's say the ISR is involving some parts of the extended vessel also, you might have to actually go for a DES too.
Yeah, absolutely. I think in my experience, I've seen that most of the time I feel like, though I think about putting a DEB, but at the end I land up with a DES just because of the reasons which you just said. Dr. Satpathy, would you have anything else to say? Dr. Milan Satpathy, are you there? Okay, I think otherwise we'll just move on to the next case by Dr. Oyon Kaur. So he's going to talk on complex case-based scenarios. And Dr. Oyon Kaur, as you all know, is a consultant interventional cardiologist at Narayana Health Rabindranath Tagore International Institute of Cardiac Sciences. So, Dr. Nag and Dr. Satpathy stay with us as panelists. So over to you, Dr. Oyon.
So thank you for those warm words of introduction. I'll quickly take you through the case, and I think, am I audible?
Yeah, you're clearly audible.
Okay, so let me, I would have very limited angiograms of the initial coronary angiogram. The reason being this was done from the angioplasty CD. So we'll have to make do with one view out here, although I would really love to give you some more views of this gentleman. But nevertheless, to give you an idea, so this is an 82-year-old male, chronic smoker, PD, bad lungs, and he's been doing fairly well otherwise, but then he's been in and out of my office for the last few months. We've been trying guideline-directed medical therapy, but off late for the last few weeks, he's been having recurrent angina, and he's been consuming up to 4 sorbitates a day. Now, it was difficult initially to convince him for an angiogram, but finally he did convince his son convinced him for an angiogram. Once we did the angiogram, this is what we see. So remember, this is despite maximally tolerated directed medical therapy. So this is a dominant circumflex. As you can see there's a tortuous significant lesion in the mid part, and there is a very tight proximal LAD disease. So definitely something that is causing all the angina that he's complaining of. So we did put him through a heart team discussion. He was deemed to be extremely high risk for ABG purely because of his bad lungs. And so in this case, what we did was we decided to go for an angioplasty. And so of course, let me show you what really happened or what transpired. So as you can see, we were initially trying to wire that circuit. It appeared, and okay, so to start off with, since this was an elderly gentleman, I tend to be more comfortable with radial interventions in elderly because of access bleedings, etc. So we started off with the radial route, and this is actually a 7 French sheet through one of our glide catheters. And you can see that this is a simple run-through wire. And for some reason, we found it extremely difficult to cross that part of the circ. As you can see, it took us almost, I think, close to 10 to 12 minutes of fluoro time just trying to get into that OM out here. So despite getting into that OM, getting in circ was just immensely difficult. So what we did was we just would just balloon out this part of the vessel, which seemed very tight, with a 2.15 New York balloon, non-compliant balloon out here. But despite so even after that, that wouldn't really go down. So we decided to downgrade to 1.2 into 10 NC New York balloon. And despite that, also it just couldn't go down. So even as you can see out here, I'm sorry. So this balloon just wouldn't go down because it managed to get to some place. We got some dilatation done out. It was typically very difficult to cross. And as you can see, there's some waste out. It was very difficult to break. So finally, we were able to place another wire into the main sub. And once it was nicely parked out there, we thought that, okay, finally we are at the end of our troubles and we should be able to land the balloon across. But as you see, we really couldn't pass any of our balloons through that angulation out there. Finally, we decided to take Guidezilla support. And through this Guidezilla support, we were able to deliver that single marker balloon to an extent. And this was followed by a few dilatations, which we upgraded then to a 2.5 balloon, and then we wanted to nicely do the same thing out here. But despite doing that, it was somehow difficult to pass our next level of stent. So this, as you can see out here, so this is basically the stent. I'm sorry, this is working. Yeah, so this is after our initial dilatation. We were trying to, so this is what the vessel looked like now. Now we have the wire parked distally. You still have the Guidezilla support out there. And so we were trying to wire this, and then it just, everything came out. So we decided to, again, this time we decided that, okay, this is not going to work. We're not going to have any more balloons, and we decided to go for a rotablation. Now, to place the rotablation wire, the biggest problem was that the rotofloppy wire needs to be negotiated through that curve into the distal L6, which itself was a big problem. So here you can see a microcatheter support. We've been trying to wire the L6 and then exchange it with the rotofloppy wire. And so let me show you rotablation out here. So this is a rotablation of the circ, and so initial pecking movements we were trying. So this is with a radial catheter in an 82-year-old man. You have temporary now inside, and he was also towards the brink of his patience. And here we were trying to get past that lesion, and that lesion was actually quite difficult to yield, but then finally gave way, as you can see in the second run out here. And we finally finished with a nice polishing run out here. So, and this is the rota polishing run on that. And then we again changed from the rotafloppy to our workhorse wire out here. And so this is the angiogram post rotablation. As you can see, the vessel looks definitely mild. Of course, beyond that, life did become a little easier, but we kept our guides just in case we find it difficult to deploy our stents. We pre-dilated with a 2.5 NC and then with a 3 NC, with good expansion. And here you would see that despite doing that, there seemed to be a little bit of a waste out here, and we finally was able to pass the stent. And as you will see out here, the Guidezilla support, the stent nicely passed through, and it wasn't very difficult. So finally, we deployed our stent. And so this is the final result of the LCA. And so this was, we had already spent close to 1.5, close to 2 hours doing this LCA, and we still had the LED to do. So the LED, although was hopefully much more easier, and we did wire and pre-dilate the LED, and we landed a 3.5 into 24 drug-eluting stent at the LED osteo. And this is what our LED final results look. But what we did see was in some of the views that there was distally also another very tight lesion, and you will see out here right in the mid part of the LED. But that day, the patient had had enough, and we as operators also were almost like close to 10,000 milligray on radiation, and we were close to more than 90 minutes on our fluoro times. So we decided to call it a day. And we took up this patient again the second day, and this was I'll show you the lesion once more. The lesion out here was this tight part in the mid LED, which was quite tight and needed to be done. So we took up one day. And of course, now that the radial had already been intervened once for the radial angio and next for the radial angioplasty, that gentleman didn't want us to go for his radials anymore. So we said, okay, fine, let's have a look at your this thing. So this is what happened. So it's weren't able to pass our catheter across the femorals on the right. It was very tight. And finally, I managed to just about get some space across the left. And as you can see, this is atherosclerotic disease of both the common iliacs. And so finally, we were able to engage the left main, and we were able to deliver another 3 to 24 drug lutein stent at about 12 atmospheres. And this is how it looks finally. So this is the final result of my case. So quick things was that in such patients, it is probably upfront important to have all forms of calcific debulking therapy on board. And in this case, we'll be talking about both rotablation as well as intravascular lithotripsy. But of course, this case wouldn't have been done without rotablation. It is the only way we could have done is with rotablation. And of course, there is a learning curve with rotablation that we're talking about. So for calcific lesions, always be prepared and do not go under prepared, because they always tend to bite you back. Over to Sir. I would start my presentation here.
Excellent case, Ayan. Thank you very much for presenting it. I think, yeah, you have rightly said, like in particular, in this case, you wouldn't have been able to manage without rota. The vessel size was small, and it was difficult to get the balloon across. So yeah, rota was the only option for the LCX. So Dr. Nag, your comments on the case, and then Dr. Shatpathy. Dr. Nag, are you there? Dr. Raja Nag? Okay. Dr. Shatpathy, are you there? The speakers are panelists as well today. So I think both Dr. Raja Nag, Dr. Siddhartha Mani is here now. So Dr. Mani, let us have your thoughts. Yes. So good evening. You're not well audible. Your microphone has to be, the volume has to be, just could you up the volume a bit? Yeah.
Sir, you're not audible. You're not audible yet.
Okay, while Dr. Mani is getting ready. So the stent in the LAD, Dr. Kaur, I think you just did a crossover from left main to LAD, isn't it?
No, sir, it's just to the ostial LAD. We did not get it.
Okay, so how did you ensure that you are actually at the ostium and there was disease in the left main?
Well, so yes, as you could directly say that this case could have done a little bit better with a little bit of imaging, but that is something that we could not afford. One, because of time, and the second, because that finances were also kind of a little. We were touched because we didn't expect rotablation to really kind of fall into place. But nevertheless, I think one of the ways to, as you said, sir, is probably the balloon motion technique. We would have looked at the circ to decide on placing the stent in the left in the ostium. But here, the angiographically, if you look at the areopodal view, so the ostium as well as is quite well placed, and we did have a very left main. So, and after the predilatation of the prox LAD, it didn't appear like we could difficulty in placing it in the ostial LAD. So here I would say I went purely by angiographically views, but yes, of course, we could have done a little bit better with a bit of imaging.
Yeah.
We actually did manage to do imaging to the LAD, but I could manage to place my IVUS catheter across the circ. For some reason, entry to the circ was very difficult after deploying the stent.
Yeah.
I think the whatever the biocompatibility of the vessel was lost.
Right. I mean, yes, it's quite an elderly patient, isn't it? Over 80 years. Yeah. And so, any comments, Dr. Nag, Dr. Mani, Dr. Shatpathy? Okay. If there are no comments, then let's move on to the next speaker. I think the next speaker is Dr. Mani. And stay with us, Dr. Kaur, Dr. Nag, as panelists, while over to Dr. Mani. I am sure you have been able to sort out the audio bit.
Yeah, am I audible, sir?
Absolutely, yes, very good.
Okay, fine. Thank you. So, thank you so much for inviting me. Let me share my screen. I will show you a Okay, so I will show you a calcified left vein bifurcation case, and with few points to discuss. My patient was a 83-year very old male, hypertensive and diabetic, with presenting with chronic stable angina and ejection fraction of 50%, with some inferior wall hypokinesia. The renal function was bit compromised. Creatinine was 1.7 and had a COPD as comorbidity as well. So this was the lesion I was going to approach. So you can see that there is a distal left main bifurcation involvement with tight stenosis in the LCX extending almost across the whole proximal and mid part of LCX, and there was also a tubular lesion in the proximal osteoproximal LAD extending almost up to proximate junction. And you can see that there are flecks of calcification visible in normal angiography as well, starting from the distal left main bifurcation itself. So I know this was a difficult case to handle, and I was in two minds regarding whether to choose a two-stent strategy from the beginning or to go for a provisional side branch stenting. Obviously, the strategy I was going to choose was very crucial here, because we all know that decay crush is the preferred technology in such bifurcation lesions. But since it was a highly calcified and diffusely diseased LCX with a wide angle, which was almost 90 degrees, the left main bit spacious, and the lumen of the left main is almost, two-thirds of the joint lumen diameter of LAD and LCX, which is the normal expected anatomy. So I thought of going in favor of culotte in this because I was a little bit skeptical about the difficulty I would face in recrossing my wire through the crushed stent struts, because once I crush the stent strut in decay crush and then I will put in another stent, I will have to face a situation where I am crossing 3 layers of stents, and that to crushed stent layers. So these were some of the thoughts going on in my mind, and I finally decided to go for culotte technique. Obviously, there remains scope for criticism and discussion here. And IVUS versus OCT, obviously I would love to go for OCT in this case, but the finance was a constraint, because IVUS in our hospital is available at a much lower cost. So I had to choose IVUS. Rotablation, left main distal bifurcation rotablation is always very complex, and there remains chance of perforation and other complications, and I would have very little time in my hand to come out of the situation if I land into such trouble. So I kept rotablation as my last resort, unless, if I am not able to do it with balloons. So I started with a Runthrough Intermediate with a 1.5 millimeter balloon support, wearing the LCX first. Obviously, I was expecting a difficult wearing, and that did happen. I had to manipulate the wear a lot with the balloon support, but ultimately I could negotiate my wear into the distal LCX. And then I did some daughtering and 1.5 millimeter balloon dilatation across the length of LCX at more or less high pressure, 16-18 pressures, which is permissible in, I mean, as much as permissible for the 1.5 millimeter balloon, and I gained some lumen area in the LCX. So you can see that it is looking little bit better. The flow has also improved a bit from TB1 to 2. So then I did a 2.5 millimeter balloon dilatation across the whole length of LCX. Then I passed the wire to LAD. LAD wiring was not that difficult. And then I did IVAS to both LAD and LCX. Now you see both the runs. I am simultaneously playing the IVAS in LCX and LAD. So you can see that as expected, the LCX was heavily stenosed with concentric plaques, almost 180 to 270 arc calcification, and in certain places you would see almost 360 degrees of calcification. It was densely calcified. Some areas was looking little bit better, normal looking diameter, but mostly it was heavily stenosed with very narrow lumen area. On the other hand, the LAD was more spacious. The lumen was a bit large in the mid portion. In the proximal LAD, you can see some calcifications, but it was not that heavily calcified. These areas, certain areas, obviously you can see it is again 180 to 270 degree calcification in LAD as well. So there was calcification present in both, but the calcification in LCX was much more severe and dense. So let me stop the IVAS runs here, and now I obviously had to modify the calcium in the ostium of LCX because, sorry, somehow my presentation got hanged. I'm extremely sorry. So let me go back. Okay, so I took a cutting balloon 2.75 millimeter to dilate the ostial LCX portion, and then I took the stent in the LCX. It was a 3.5 millimeter into 38 millimeter disc in extending up to almost 2-3 millimeters into the left main, and distally it went up to mid of LCX. It was more or less the expansion was looking good. I had to rewire. This was what I was mentioning, that the rewiring to LAD and subsequently again in further steps was a little bit easier for me because I choose pull-out technique. It would have been much more difficult had I gone for a decay crash. So that was one of the reasons why I choose pull-out, and still you can see that where rewiring was so difficult to LAD, but I could manage somehow. And then after I rewired into LAD, I took a high pressure dilatation in the ostial LCX with a 4 millimeter balloon. So that was followed by a opening of the strut into the LAD, and I took a 2.5 millimeter balloon to open up the struts so that I could negotiate my stent now into the LAD. 2.5 millimeter dilatation was followed by a 3 millimeter dilatation in the ostial LAD extending up to the distal left main bifurcation. That would open the strut. create more area and make my stent movement easy into LAD. And then I took again a 3.5 millimeter, but now a shorter stent, 24 millimeter into 3.5 into the LAD. So traditionally, what in culotte, what we do is we place the second stent a little more proximally. The proximal end of the second stent comes further proximal than the previous stent, but here it is sort of something like a reverse culotte sort of strategy where I left the stent. It is sort of modified tap, you can say, something just protruding into the left main. So I did those things because the left main was short, and if I was coming further proximal, then I would have almost reached the left main ostium. So that would have been again difficult, and in any case I will not have a adequate size for a pot because the left main is already short. So I did it in a little bit modified manner. I left the stent here, and then this was the immediate result, you can see. So I followed it with a kissing balloon dilatation, 3.5 millimeter each in both LAD and LCX, and this was the final result. So a little bit my own modification considering the anatomy of the patient, and this is the final thing. And I did final OCT, IVAS runs, and you can just go through the run. These are the, this is done in LCX. The IVAS was, final IVAS was done in LCX, and these are the mid-distal portions which I did not touch. I stented it from the mid LCX. So more or less the apposition and expansion looks okay. Lumen gain was also more or less satisfactory. So now you come into the left main. So this was the final carina in the IVAS. So that's it. Thank you, sir. Let us discuss the case now.
Yeah, well done, Dr. Bani. I think let's, so Dr. Ayonkor, your comments. Let's have the comments first, and then we can discuss different issues.
So firstly, Manida, congratulations on a very well done case. Of course, we can always discuss regarding the decision to choose culotte as the method of seeing this bifurcation, but I guess that is what is, I think it's the priority of the operative. If you're comfortable doing a culotte and with the kind of images that you've shown post-stenting, I think we have adequate MLAs at both the left main ostium, the polygon of confluence, the LAD ostium, as well as the ostium of the LCX. Of course, in the left main, I've done a little bit more post-dilatation, if I'm not wrong. Maybe you must have done it after the IVAS, I guess. But apart from that, it was a very well done case. So I just wanted to know the reason behind doing culotte here. Was it just a short left main, or was it just that you find it difficult to cross through 3 layers of stent if you did a DK crush? Because somehow here.
yeah, I had all those things in my mind. I thought the angle was good enough for a culotte as well, and since I would have faced much difficulty had I shifted some calcium spars and all those things. I mean, I was not sure what was going to happen after I do a cutting balloon in the LCX ostium, and then whether it will be very difficult for me to re-enter the LAD through those crushed stent strut layers. So that was going on in my mind, and you always know that recrossing through a culotte technique, I mean during a culotte technique, is little bit easier. And as you were telling that the left main was also very short, so and I had very, I mean the area where I was going to manipulate so many wires and balloons, that area was very short for me. So I thought of choosing culotte. I mean I had a lot of confusion in my mind. I discussed with other people whether to go for DK crash or culotte, and ultimately I chose it. So yeah, I landed up with a decent final result. But maybe DK crash, somebody else doing a DK crash here, maybe they could have got a better result. I don't know.
Yeah, well, see, it's true that decay crash has been shown to have better results compared to the other techniques that we know, but we have to consider each patient individually, I mean, on its merit. And if you look at this patient, is some 83 or 84-year-old man who had a creatinine of 1.7. So, of course, we wouldn't really like to do a technically excellent case fine and then land this patient into renal failure or something. So I think I would have done the same thing, though I would have compromised a better outcome with rather, rather I would not going into immediate problems. Yes. So in that case, I think it makes sense in this particular case to go with any procedure which would be less time consuming, less contrast, and get it done quickly. So that's fine. Yeah. And Dr. Nag, are you there? Raja?
I just have one question. Manida, you said you wanted to use OCT. Why OCT?
OCT I did not use because of the cost factor.
Apart from that, in a left main case, I think you wouldn't. The spatial resolution of IVS is generally more useful than OCT. And here you, because of the calcium, I guess you were planning to use OCT. Is that what? Is that the reason?
No, actually, I mean the. I am more comfortable, rather to say, in doing left main bifurcations with OCT. I think and I mean the image quality and everything, the calcium also, I am little bit more comfortable with doing a OCT here, but because the cost, as you know, is almost thrice the IVAS, so I had to choose IVAS here.
And I think your creatinine was also on the highest.
Another thing was the creatinine was a little bit high, so I would have, I mean, I could reduce the dose of contrast with this IVAS. So that was another reason.
Right, sir.
Yes, Dr. Nag. Yeah.
So did you ask me anything?
Oh, no, I'm saying your comments on this case?
Yes, I totally agree with you. OCT would have been a better modality, but because we know our patients always have this financial restriction, so we have to do what we have at hand, and he did very well with this.
There's a lot of background noise from
some network issues.
Yeah. So, on any other? Anyone else would like to make any other comment?
No.
Dr. Kaur? No?
No, sir.
Okay. No, I think these are brilliant cases that we have seen so far. And I think our last speaker was Dr. Shotpati.
So Dr. Shotpati had some issues. He has to drop for today's webinar.
I see.
He has some case on the way to his cath lab. So sir,
Right.
you can conclude
Okay.
for today's session.
Fine. So yeah, so we had some lovely cases here and wish we could have more discussions on this. But I think, yeah, so let's conclude the session. And I would like to thank the participants, Dr. Mani, Dr. Kaur, Dr. Nag, and also thanks the Abbott team for arranging this event. And yeah, so thank you very much. Okay,
you.
so
Thank you. Good night.
good night. Good night.
Thank you. Good night, sir. Good night.
Thank you, sir. Good night.